Hello, everyone, and welcome. Good evening, good morning, good afternoon, wherever you are. I'm Sabine Giraud. I'm a Stanford Professor Emeritus in surgery, and I'm going to be the moderator today, together with Zain, my dear friend and colleague from Jordan. Zain, do you want to introduce yourself?
Hi, everyone. It's a pleasure to be here and a pleasure to have you all. Very excited about this evening's talk by Dr. Casey Lee. I'm Zain Goussous. I'm a maxillofacial surgeon based in Amman, Jordan. And yeah, I hope you enjoy this evening.
So today we have a really special event. It's my great honor and pleasure to have Dr. Casey Lee on Surge On. I think Casey you don't really need an introduction. Dr. Lee is one of the founding fathers of orthognathic and sleep surgery in the United States. He and his colleagues actually started the field of sleep surgery, I think in 1989, if I'm correct, and I think you'll talk a little bit about that, how that all started. And I think there is no person in the world who has more and more excellent experience in sleep surgery and orthognathic surgery. He is my colleague here at Stanford, and he's just a wonderful person and speaker and one of the most experienced people in this area in the world, what we really call a living legend. So Casey, again, a warm welcome to you, and please introduce yourself, and we are very much looking forward to your presentation.
Thank you. That's such a great introduction. I don't know I could live up to that, but I will try my best. It's a pleasure to be here. I am, I like to try to make this very informal. I'm just going to sort of share my experience with you. I'm going to start sharing my slide.
Mm-hmm.
Everyone could see?
Yeah, it looks great. Mm-hmm.
Okay,
yeah.
Great. Okay, well, as Sabine was saying, that I've been doing this for a while, and when I'm going to talk about maxillomandibular advancement surgery for sleep apnea, and there's a lot of things to consider. When you get to a certain stage of your career, you start to reflect. I'm at that stage, and there we go. I started really focused on sleep surgery in 1997. That year, I was just finishing up my fellowship in facial plastic surgery. I did a residency in oral maxillofacial surgery and then followed with otolaryngology head and neck surgery. And after that, I was doing my facial plastic surgery fellowship and finishing in 1997. And when you're trained in several things and you wanted to sort of do everything, but I realized I couldn't. And I was talking to Nelson Palo, who by the way was an MD and otolaryngologist. He did a year of oral maxillofacial surgery training, but decided to go into otolaryngology. And his partner was Robert Riley, who was an oral maxillofacial surgeon and otolaryngologist. So their practice really intrigued me, and so they asked me to join them. And there I met Dr. Christian Guilleminault, who really is a father of sleep apnea and upper airway resistance syndrome, and really to me, the person that started the sleep field. So since that time, I started doing a lot of maxillofacial surgery, not just for regular orthognathic surgery, but also focus on airway and sleep. So maxillofacial surgery for sleep really sort of started. Let's look at some historical perspective. The first paper that was published with mandibular osteotomy for the treatment of sleep apnea was by Paul Kuo. Paul Kuo actually went to or trained at the same institution that I did at MGH, as well as Roger West and Dale Bloomquist, where they published a paper on 3 patients that were treated with mandibular advancement. Now, this whole thing about maxillofacial anatomy, cephalometric, and that sort of thing was really published, first published by Andrew Jameson and Christian Gimeno and Marco Partinen. Both those folks were fellows or sleep fellows with Dr. Gimeno at the Stanford Sleep Clinic. So that was really the first paper that started talking about cephalometric maxillofacial anatomy involving in patients with sleep apnea or sleep disorder breathing. Now, there's been hundreds and hundreds of papers that's published since then about cephalometrics and maxillofacial anatomy in association with patients with sleep disorder breathing. But I just want to say a couple of things. And what the paper discussed remains true today. Sure, patients with sleep apnea tends to have more of a cephalometric abnormalities, or sort of what we call abnormal, maxillofacial structures. But just because you may have some maxillofacial abnormalities, that does not mean that you have sleep apnea. The converse is true. Just because you have quote unquote normal cephalometric measurements or what have you, that does not mean that you don't have sleep apnea. Okay, sleep apnea is a very complex issue. So the anatomy is just part of it. And obviously, as surgeons, we focus on the anatomy, but I just want to make that point. Obviously, we're going to talk about MMA. Early days, I used to think, okay, well, we're moving the upper lower jaws forward, make the airway bigger, and that's what it does. And I've always been very interested in the impact of advancement. That was back in, you could see that, 2002, very, very early on. I did a study where I did pre and post cephalometrics and fiber optic assessment. I also did a airflow meter in terms of looking at, the inspiratory effort, changes or maintain the inspiratory effort, but looking at how the airway collapses. And, it remains true today in that MMA certainly opens up the airway, expands the airway, but also lessens or improves the tongue-based collapse. And more importantly, what I found in that study was that the lateral wall improvement, sort of the lessens the collapse of the lateral wall, was the most dramatic. And the same thing was reported earlier by Rich Schwab, who's a sleep specialist at UPenn, where he found that the impact of CPAP is actually greater on the lateral pharyngeal walls. And so when you look at the entire airway, the lateral wall really is the most compliant aspect of the anatomy, not the tongue, but the lateral wall. Okay. So these are sort of photos from that study. You could see that pre and post. You see the tongue base is advanced forward, the epiglottis is pulled forward, etc. But what's interesting is that we maintain using the same inspiratory effort, you could see that the lateral wall collapse was dramatically improved. Okay, so MMA does a number of things of the upper airway, not just making the airway bigger, but also lessens the collapse. And most importantly, the airway improvement often comes from the reduced collapsibility of the lateral wall. Recently, I've done a number of CTs and computational fluid dynamics, really just to try to analyze the airway, how the airway respond, and potentially how we could do the operation to make it more predictable or identify favorable candidates versus unfavorable candidates. And this is a study with looking at CT, just looking at different levels of the airway, looking at lateral dimensions, AP dimension, cross-sectional areas. And obviously, MMA improves the AP dimension, improves the lateral dimension, improves the circumferential airway. And the improvement of the airway is correlated with the skeletal movement, i.e., in general, there's a trend of greater airway improvement with greater advancement or larger airway. Okay, it's not a direct correlation, but you can see that it's fairly predictable. Larger advancement, bigger the airway. And we know by physiology, we breathe by negative pressure, right? So we expand our lungs, we inspire and draws the air into our lungs. So the upper airway is just a conduit, okay? So with computational fluid dynamic analysis, pre and post, you see that when the airway's larger, there's less sort of improve or lessens the negative pressure that you have to generate to breathe. So it reduces the negative pressure of the airway after surgery. It reduces the velocity of the airflow during surgery because what I call it the comfort of breathing. It's more comfortable to breathe. It's easier to breathe, and you don't have to generate as much effort to breathe. Okay, and in terms of the pressure, you can see that the larger the advancement, the less the airway pressure, and the pressure and velocity improvement is correlated with the AP dimension, is correlated with the lateral dimension, and is correlated with the circumferential airway dimension. Okay, so again, in general, larger the airway, more comfort or the ease of breathing improves. Now, there is kind of a threshold in that when you get to a certain point, certain dimension, there's a fairly dramatic improvement. Okay, so and you know, back in the days, pulmonologists would like to talk about peak crit, you know, the pressure when the airway really collapses. In some ways, true in that when you do an MMA, you get to a certain dimension, and the improvement on the airway, it becomes much greater. Okay, so, but yes, we could do a lot of things with MMA, but what it does not do, okay, it does not alter the neuromuscular relaxation of the individual. Some patients' airway just more collapsible than others when they're asleep. Okay, so that we cannot change, but we could change the anatomy and just basically improve the airway dimension. And we cannot change the arousal threshold of the individual. Some people just have very low arousal thresholds, so that although you improve their airway, they may be improved, but improvement may not be sufficient in terms of significantly improving their symptoms. For example, after MMA, you significantly improve the patient's AHI or RDI, what have you, but because they have such low arousal thresholds, even though the sleep studies show that their index may be much lower, they continue to be very symptomatic because they have such arousal thresholds. Okay. Now, enough science. Let's talk about data. Okay, so this was published last year, but I finished collecting data a few years ago when I hit 1,000 MMAs on sleep apnea patients. Okay, so you can see that MMA results can be fairly dramatic, right? In about 950 patients. The RDI, I like to look at RDIs rather than HI, okay? Because overwhelming majority of your patients are there to see you, not because they're afraid of high blood pressure, heart attack, and stroke. They're there to see you because they don't feel well. They don't sleep well, they wake up, they're tired, etc. They're there because they're symptomatic. So to me, the RDI is more representative in terms of measuring improvement with more of a symptomatic change. So I usually look at RDIs, and you can see that RDI can be fairly significantly improved, okay, from 39 to 13.6. But keeping in mind that is 13.6 is not zero, okay? A point I want to make is that nobody cures sleep apnea. In my opinion, we all have certain degree of sleep apnea. Okay, I have it, you have it, everyone has certain amount, certain degree of sleep apnea. It depends on how severe, how symptomatic the individual is. But with surgery, we could certainly improve them quite a bit. And we could see that we could improve patients from a severe level to a very mild level, improving their oxygen saturation, improving their quality of sleep, improving the sleep stages, etc. So there are a lot of things that we can do, okay? However, still keeping in mind that it doesn't mean that you're going to completely eliminate sleep apnea. But if you take a look at what the MMA can do, is that it is not 100%. The cure is not, the improvements It's not 100% of the patients. If you look at the criteria of defined as surgical cure, RDI less than 5, it's not great at all. Okay. But if you look at improvement, overall, 70-some, 75, 80% overall, fairly significant improvement. That's what I usually quote my patients. One of the reasons that I wanted to publish this study was to really point out that from a single surgeon, you see a lot of papers, or at least back in the days, people would report 95% success rate, 90% success rate, what have you. And that's what commonly talked about with MMA. But that's not really true. Okay, if you look at all comers, I usually tell patients that, probably depending on the characteristic of the individual patients, and you can sort of give what I call an educated guess in terms of how well they're going to feel or improve based on historic data. Okay, this is a busy slide, but if you sort of look at, tease out a lot of information, you could see that when you stratify by the level of severity, you could see that patients with very severe sleep apnea tends to be a little older. Okay, certainly more overweight. Every time I do a surgery on a sleep apnea patient, I tell them that your weight is going to be your biggest enemy going forward. Okay, I consult every patient on changing their lifestyle, maintaining a healthy lifestyle, because I could do an operation, but the patient continues to, if they gain weight, their sleep apnea is going to worsen quicker. Okay, so weight is always an enemy. You could see that overall from less than 30 to greater than 30 RDI, you could see significant increase in weight. And in terms of, this is self-explanatory. So you can see that patients with less severe sleep apnea tends to do better than patients with more severe sleep apnea with MMA. And that's, it's certainly logical, right? The predictor of surgical outcome is pretty straightforward. Younger patients do better. Patients who are normal weight do better than patients who are overweight. Patients with less severe sleep apnea tend to do better with patients with more severe sleep apnea. And the greater degree of advancement, the better the improvement. Okay, so if you look at the evolution of MMA in treating patients with sleep apnea, it has changed significantly. Early on in my career, I would say probably the first 10, 15 years, MMA was really used as last resort. Okay, it was known as the Stanford protocol. Phase 1, phase 2. First, you do soft tissue surgery, smaller surgery to try to improve patients, and we reserve MMA as sort of the much bigger operation in patients who continue to have problems. So you tend to see patients who are more severe back in the days, and the patients who are overweight and that sort of thing. But I would say the past 10 years or so, it has changed. Patients, MMA has become more of a the primary surgical treatment. A lot of patients will forego the less invasive surgery or what have you, go straight to MMA. A lot more patients are interested in airway improvement, but also focus a lot more on aesthetics. Okay, so there you can see the difference. So when we tease out the first 500 versus the last 500 patients, you can see that patients are now younger, okay? And they certainly weigh less. They're less severe, okay? You see how severe patients were before, and now they're less severe, okay? And these patients tend to do a little better compared to patients who are older or more overweight. I want to emphasize, and this is something I talk to every patient about when they have surgery, is that time does not stop when I do an operation. Patients continue to get older. Patients continue to gain weight most people, it's commonly said that after college, on average, we gain a pound a year. Okay, so I certainly weigh a lot more than when I graduated from college. So weight, again, is always going to be your enemy in terms of trying to maintain the success that you've gotten. Okay, so the natural history of sleep apnea is going to get worse. It gets worse for everyone, regardless of what you do, because that's part of aging. Okay. And obviously, there's some bodily changes, which I'm not going to go over, but the bodily changes, change of pulmonary functions and what have you, it gradually worsens. And you could see epidemiology study that you see that the prevalence of sleep apnea increases as we get older. All these are factors in terms of looking at surgery and how we can help our patients, not just right when you do the surgery or a month after surgery, but I'm going to show you a patient or two that, that unfortunately, they come back to see me after a while. Okay. Now, we talked about a bigger airway is always a better airway, which is true, but what's the cost? Well, there are a number of disadvantages of doing a big operation or a significant advancement. And we'll talk a little bit about that. Okay, because what I always tell patients is that the more I advance the jaw, the better your airway is going to be. But it's going to get to a point where your aesthetics is going to be compromised. Every patient is different. Okay, some patients are here, their sleep apnea may not be as bothersome to them. They're using this operation as a treatment of sleep apnea, but they're very focused on the aesthetics, as opposed to another patient where they've struggled so much. And often they will say, I don't care what I look like. I just want to sleep better. Okay. Early in my career, I believed them. But now I don't, because when patients sleep better, they care about how they look. Okay. And you should always take that into consideration. I've always been interested in the changes of facial changes, facial aesthetics, and MMA. This was old study, and a couple of old studies you could see back in 2000. I was always interested in the response pace, because some people just don't like changes. Okay. That doesn't mean that their aesthetics are worse, but they look a bit different. And different means different things to different patients. Okay. That's something that you have, if you do a lot of aesthetic surgery, it's all about psychology. Okay. So, all right, let's talk about the patients a little bit. This patient is in his 30s and he came to see me. Okay. He's has sleep apnea since he was a teenager. He was on nasal CPAP. Okay. And he was my patient. In 2009, he's from the Pacific Northwest. He came to see me. He had mild sleep apnea, but very, very symptomatic. And he was heading to college, and he was very compliant with CPAP. But he didn't want to use CPAP to go to college. I only know of one or two of my patients that still uses CPAP when they go to college. When they go to college, they're out of the house. What they do whatever they want to do, and which means that they usually don't use their CPAP. So I did it. You could see the facial changes from 2009 to 2023. The aging process. I wanted to. There's several issues with this patient. Not issues, but several things that I want to talk about. Look at the facial changes. So 2009, that was post MMA. Okay, I advanced them, and you could see that the maxilla underwent some sort of retraction with aging. And look at the maxilla. There's gradual retraction. Okay, because the patient, although I did MMA, and his septum was straight and what have you, but his nasal breathing was never great. I do think, and that's why over the past several years, in addition to MMA, I've been really focused on the improvement of nasal breathing, because it's, you know, some people say, okay, well, you're going to do an MMA and everything's going to be great, but it's really not true. MMA is a great operation, does a lot of things, but some people can still be, they still have problems. So basically, you can see this patient underwent a fair amount of changes in terms of, you know, contraction and retraction of the maxilla, and in some ways the mandible, I think. Okay, so let's talk about aesthetics. So this patient, you know, in 2000, just so happens in 2009, prior to 2009, I used to use a blue background, and that was about the transition time. So the pre-op was blue background, the post-op was white background. But anyways, you could see the patient had, the face is slightly long, and the upper lip was slightly deficient. Okay, so I did an MMA on him, and he had a little bit of VME, which I corrected. But you know, with correction of VME, you're going to widen the nose a bit, right? Especially in this patient. You know, I did a lot of rhinoplasties in my career. I could tell you that one of the most difficult nose to fix is an upturned nose. Okay, if you advance the maxilla, we all know that it's going to upturn the nose. We impact the maxilla, it's going to upturn the nose. I did everything I could to try to limit further elevation of the nose. Okay, because, you know, I sort of imagine if the patient's unhappy with the nose, and I have to sort of reconstruct it or do a rhinoplasty, you know, increasing the length of the nose is one of the most challenging aspects in rhinoplasty. So he was advanced, and you could see that back in 2009, that was the operation. A bit of a counterclockwise rotation, no, not a dramatic one. And I think he was advanced. I don't know. I think I traced it out somewhere around 11, 12 millimeters. And, you know, I think, so I like to look at the advancement, obviously based on a panorama radiograph rather than a supplementary radiograph. So you could see the gap of the osteotomy side. So would I do anything differently today? 2000, you know, that's 14, 15 years later. You know, all I would do today is that I've changed, you know, everyone does big advancement nowadays. You know, back in the days in 2009, that was a pretty big advancement. Today, I would most likely do a couple of different plans, and which I'll go over. But you know, I don't think I would change dramatically in terms of my surgical planning for him, because aesthetically, I will consider him a pretty decent outcome. Now, if you're going to do a good operation to manage sleep apnea, all your patients are going to have abnormal cephalometric measurements. They're all going to be more prominent, okay? And early days, I used to see a lot of failures refer to me or come to me for a second opinion. Is that people used to think, oh, I'm going to make this individual, that this patient has abnormal cephalometric measurements, I'm going to make them normal, which meant 3 millimeter advancement, 4 millimeter advancement. You know, again, and which is what I talked about when I talked about in the literature, is that normal ceph does not mean normal airway or no sleep apnea, okay? So the management of a patient with sleep apnea is basically looking at the facial aesthetics and assess how the advancement is going to impact on the facial aesthetics, and then how much can you advance without compromising the facial aesthetics. So I don't remember the last time I did a ceph analysis. It's all about position of the soft tissues. And everyone's soft tissues are different, okay? You can look at the thickness of the chin, soft tissue. So, you know, I was never a believer in using ceph, because at the end of the day, it's not the ceph, but it's really the soft tissues that determines facial aesthetics. And you talk to some of the many surgeons who does a lot of orthodontics, nobody does cephalometric analysis and follow the cephalometric analysis, because again, it's the soft tissue. So on that patient that I just talked about, the young man, his soft tissue was pretty on the thin side. So it depends on the thickness of the soft tissues, what have you. So in general, patients with thinner soft tissues tend to the movements tend to show a bit more. Okay, so just the point about the soft tissues. Now, I operate on this patient. Okay, so some people will say, "Gee, this Lee guy, he doesn't know how to make do an MMA surgery." This patient, I like to use Asian patients because they're, to me, the hardest patients to do MMA and still maintain a good aesthetic outcome. Asians tend to have sort of more shallow face, right? The nose is much flatter. You can see that the patient has, I will call a pretty prominent maxilla and mandible. Okay, well, I lied. I didn't do an MMA on him, okay? I try to do a lot of different operations, but not an MMA. So you can see that there is no way, if I do an MMA, that this patient is going to have a good aesthetic outcome. Sometimes I hear, "Oh, well, look at this patient. The surgeon did a bad job because, X, Y, and Z." Well, you have to look at what you were dealt with. And some people say, "Well, you should have never done an MMA on him," okay? Because aesthetically, it's not pleasing, or because it's too prominent. Well, let me just say this. This patient has been trying CPAP for years. He's a young man. He's very symptomatic. He had a number of surgeries, and then he tried BiPAP. He continues to have moderate sleep apnea, very symptomatic. Okay, so what would you do? Right? The patient continues to sort of want to get better. Obviously, no one should blame him that he wants to get better. So for him, I dread doing surgery for him because I'm very concerned about the aesthetic outcome. But I'm going to come up with 2-3 plans and really sit down with the patient in terms of going over the potential negative impact. And at the end of the day, some people are so symptomatic that they just want to sleep better and feel better. Okay, and you're going to see patients like these, that they are aesthetically, they're a challenge in terms of doing an MMA. This is a patient that I operated on 2.5, less than 3 months ago. I'm using these patients because my approach has sort of changed recently, and I'm going to go over. Okay, so number of things about this patient. First of all, this patient is young. She's extremely concerned about her facial aesthetics. She is very symptomatic, and she wants to maintain the I don't know if any of you watch K-drama, the Korean drama, okay? Asian beauty is feminine, in women is femininity, okay? They don't want a strong jaw. So there's a problem, right? And one other thing is that this patient has bilateral condylar resorption. So she has a significant mandibular deficiency. I know this is not a TMJ talk, and I'm glad it isn't, but I've done a number of MMA surgery on patients with prior to condylar resorptions, what have you, and obviously they're stable. There's been no change, and she's asymptomatic. She has no pain, no restrictive functions, what have you. So I told her that I have no problem operating on her. Okay, so for this patient, so for a little over a year now, for a number of patients that I've been doing, with the ease of VSP, that you could, really design different plans. The first patient that I talked about, the age, that I operated on 2009, when we were still doing model surgeries, if I do 2 or 3 plans, I'd be in the lab all weekend. Okay, so that's just not, and the model is going to break and whatever. It's not feasible. But the VSP has allowed me really a tool to be able to offer patients with different options depending on their concerns. So in this patient, because she's very, well, you have opposing goals. She wants to feel better, but she doesn't want to look bad. And in fact, she wants to look better or look good. Okay. So what I usually do is I come up with at least 2 plans. One's an aesthetic plan, one's an airway plan. And sometimes patients will say, no. For example, this patient, she chose the aesthetic plan. Okay. She said, I want to put the aesthetics as my top priority. And what I told her was that, well, okay, that is fine, but you understand that you may potentially have less airway improvement. Okay, there's higher risk of still have some symptoms. At the end of the day, patients are the boss, and they're going to decide what they want in terms of their treatment. I will say that I've looked at a ton of patients intra-op, not just sleep MMAs, but also regular orthognathic MMAs. And these patients are paralyzed during surgery. So I could look at their soft tissue characteristics. There is a definite soft tissue characteristic in terms of how the soft tissue responds when the jaw is advanced. So if you look at some of your patients, when you do an MMA, and when you look at their airway opening or airway enlargement, it's variable, okay? You could do a 15, 16 millimeter advancement. Some people get a tremendous response. Some people get an okay response. So it's variable because there's certain amount, there's in some patients, there's a certain amount of soft tissue collapsibility. And I urge you to sort of look at how, during surgery, look at how the tissue responds. And a lot of times I would tell patients when they're open to either plan, I would say, I will go with the aesthetic plan if that's a main concern. But if you are agreeable, if I analyze the soft tissue and that I'm concerned about the collapsibility, that I will go with the more advancement. And some patients will say yes, some patients will say no. Just one patient came to mind that this patient had a fair amount of parasomnia. I operated on him about a year ago. He was a young man, but very symptomatic in terms of his parasomnia is such that he becomes combative and that there's no way he could use CPAP. So surgery was his only option. I gave him 3 plans, and I told him the 3rd plan is a huge advancement. He's not going to look very good. But plan 1 and plan 2, he said, okay, well, I will go with the first plan, more aesthetic. Second plan, if you really think that it's necessary based on your sort of soft tissue, my soft tissue response during surgery. And his soft tissue was so floppy that I felt compelled to do the larger advancement. And he was much better, but he still has some symptoms. Okay, so I felt better doing the larger advancement just based on looking at the collapsibility of the airway. So this just sort of reminds you that the soft tissues, we're moving the jaws, but really we're impacting the soft tissue. So this is the young woman that you can see that the initial plan or the aesthetic plan versus the sort of more advancement. Okay, and try to advance her airway. I'm not saying that the airway plan is going to make her look bad, but it's just going to be a little bit more prominent. May not be what she wanted in terms of a feminine appearance. So that's plan 1. Okay, so you can see the amount of condylar resorption, but I've done quite a few patients and they've done fine. Okay, and some counterclockwise rotation. So that's her result. Now, you would say, well, you know, her chin, she wanted a little bit of chin deficiency so she could look more feminine. Well, I put her there because she had a lot of fillers on her chin. Because she has such mandibular deficiency, she had a huge amount of fillers injected prior to surgery. So calculate, again, that's sort of analyzing the soft tissue, because that amount of soft tissue is abnormal. So I'm looking at, you know, at least a 50%, you know, probably 5-6 millimeter soft tissue resorption at the chin point. So that is going to put her, you know, at a decent position, and decent position once the fillers have dissolved. Okay, so this is 2.5 months. She sent me her photo. She's out of town, so you know she's very happy. You can see now. One thing about Asians, you know, I routinely, you know, I really try to focus on the nose because it drives me nuts when the nose changes so much. It's tough to manage Asian noses. I routinely do alar cinching and subspinal osteotomy to try to preserve the musculature. But in Asians, the ANS and the muscle attachment is really weak. So you can't, most of the time, you can't do a good subspinal. But anyways, you know, she's happy with her appearance. Now, this patient has sleep apnea, and he was very concerned about how he's going to look. Again, it's a balance between aesthetics and airway improvement. He heard that, oh, you know, I don't care about the aesthetics and I'm going to do huge advancement on him. He's not going to look good, et cetera, et cetera. Well, I think that's false. Every patient, regardless whether they come in for orthodontic or for sleep cases, it's the same. Okay, they're analyzed the same. So for him, I did 3 plans. Okay, for the treatment of sleep apnea, I would not do a treatment plan. 1, I just don't think that it's sufficient. Why? Because he's young. He's going to continue to worsen. I say, you know, I know he was very concerned about aesthetics. I'm going to say, I think that plan 3 with the, you know, the mandible coming in about 15 is about right in your case. But I could do plan 2, but you're going to be still be a little deficient. He was so concerned about aesthetics. He said, okay, well, I just want to do plan 1 or plan 2. I don't want to do plan 3. Okay, so I did plan 2 on him. You can see a bit of a one thing about counterclockwise rotation. Now it's like it's a dogma. You know, if you're going to do sleep apnea MMA, you have to do a counterclockwise rotation. Well, I do a rotation for almost all the patients, but I'm not a big believer in a huge rotation because I'm not convinced that a huge rotation is really going to be better than a straight advancement for airway wise only. Okay. I do a rotation more for aesthetics than for airway improvement. And I actually think that maxillary advancement is going to give you a better improvement in terms of lateral wall opening and collapse. It's the mandibular advancement that sort of brings the tongue base forward. And you know, everything sort of it's everything. Okay, so did a bit of rotation, a bit of advancement, and you know, that was plan 2. Aesthetically, I think it's fine, but he's to me that he's still slightly deficient, but he was happy. He goes, "Yep, you told me that I'm still going to be a little deficient. I'm okay." So, you know, at the end of the day, it's to satisfy the patient's goal, you know, and you have to try to strike a good balance. I want to talk a little bit about prognathic class 3. I treated a lot of patients with class 3 malocclusions, huge mandibles, but with sleep apnea. Just because you have a huge mandible, that does not mean that you don't have sleep apnea. And there's a ton of reports on setting the mandible back causing sleep apnea. So I'm really careful. And every patient, again, whether they come in, even when they come in for straight orthodontic, I ask there's something about sleep apnea and make sure that, you know, I'm not missing anything. Okay, so this patient, you know that she's going to get better aesthetically, but most of the 95% of the surgery was on the maxilla, lengthening, advancement, and teeny bit of rotation and very, very small amount of setback. Okay, so usually so when you lengthen maxilla, you get less nasal changes, right? So now, what's the difference between this patient and the younger girl? Well, this patient is in her 40s. She was referred to me for class 3 malocclusion. I started talking to her, and she's a habitual snorer. She occasionally wakes up at night, and she's in her 40s, and she's going to hit menopause in about 10 years, okay? And her sleep apnea is going to, boom, just drop. It's so in someone like this, you know, I talked to her about aesthetics. Obviously, aesthetics is her focus, but I try to educate her about the airway and sleep apnea, et cetera. So would you say that she's a little stronger and then what I would determine aesthetically ideal? Yes, but again, every patient has different factors you want to satisfy. But if she said, you know, my goal is aesthetics, I want a certain type of appearance, then so be it. As long as I did my job in terms of, again, most of her surgery was maxillary. Okay, a little bit of mandibular rotation. Okay. It depends on what, and I think that she's improved significantly aesthetically, and her airway was much improved. She doesn't snore anymore. I know, at least in addition to help her occlusion and I think aesthetically and airway wise, I've helped her. Now, not every patient needs MMA. I operated on her at, I think, 2009, 2010. I did maxillary surgery only, okay? And she had no sleep symptoms, and I didn't want to compromise her airway, okay? So maxillary surgery only. She had a little bit of a vertical deficiency, so I lengthened her a little bit, lower her a little bit, so that aesthetically, you could see that she had in my opinion, a good outcome. Now, this patient, 43 years old, he was referred to me for class 3. I start talking to this patient. He snores. Sometimes he wakes up gasping for air. He didn't come in for sleep apnea. But so, again, every patient is an aesthetic patient, and every patient is an airway patient. So what do? I refer him for a sleep study. 48 years old, severe sleep apnea, referred to me. I told him that he's a poor candidate for MMA. I asked him about nasal breathing, CPAP, et cetera, et cetera. He couldn't tolerate nasal CPAP. And I said, well, are you willing to use CPAP if you can use it? He goes, yeah. He goes, I don't want a big surgery. I just want to be able to sleep better. So I think he's on my schedule for nasal surgery in a couple of weeks. My goal is not to do MMA. Why? Because weight. The weight is a negative prognostic factor. Okay. Even if I'm able to do an MMA, wire his jaw, he loses whatever pounds, it's going to come back and your surgery is going to fail. And I don't want to see patients back, and I don't want failures. Okay, so some of you will say, hey, you know, this Lee guy, you know, talks about doom and gloom about MMA. That's not true. MMA is a great operation, but it's just not 100% successful. I know that because I've seen a lot of failures. West Coast, East Coast, West Coast. Patients had, you know, jaw surgery for sleep apnea, continues to suffer, even if they had a good advancement. And all the revision surgery I've done, by the way, huge counterclockwise rotation, still has sleep apnea, and huge counterclockwise rotation. I would just also say, say two things. Number one, I've seen a number of large rotations with malunion, non-unions that came to see me for a second opinion. That's number one. Number two, in my career, I had to reoperate on two patients. One was, I think 15 years ago, that the midline was off. I couldn't stand it. That was with model surgery. So I told the patient, I said, I'd like to correct that. That was one. The second one was a 50-some-year-old man that I, with moderate severe sleep apnea, did a rotation advancement. Everything went fine, but he said his swallow, the way he swallows is different. He feels like the soft palate is hitting the tongue all the time. So I revised him, put him back 50%, and the swallowing impact went away. So I would be a little careful in terms of doing a large rotation, okay? Not to mention the stress on the condyles and what have you. I've done a lot, unfortunately, too many revisions with people that continue to have sleep apnea after their initial MMA. I don't want to do revisions. When patients come in for revisions, I tell them it's twice as hard, twice the complications. And I just did a revision about a month ago. That's probably the hardest MMA I had to do. Paper thin maxilla, huge amount of scarring. I had to take out the road disimpaction forceps and really try to advance them. Why? Well, this patient has had all the surgeries, including Inspire. He's his 30s. Okay, he's young. So, I think that was the second time I called the family intra-op and hoping the family would say, oh, no, stop the surgery. But I sort of press on. I was able to advance them. Now, a note, I'm going to finish up with this comment about revision surgery, and we'll go to discussion. Revision surgery is never as good as if you did a good primary surgery. Whenever I do a revision surgery, this guy, I did 3 plans because I just don't know how much scarring is going to hinder the advancement. His initial advancement was 5 millimeters. Okay, it's just, he doesn't even look great aesthetically. Okay, so throw away your cephalometric analysis because if your treatment for sleep apnea or aesthetics is a soft tissue. So I am going to stop here and open up the comments and discussion. You're muted, Sabine.
Can you stop sharing? Then we can see everyone. This was a fantastic presentation, and I think I'm sorry to say you really lived up to your reputation as one of the living legends here. I don't know anybody else who's done these many surgeries for orthognathic and sleep apnea, and I really enjoyed also how you described how your thinking has evolved over time. So I think this is very important to learn as a surgeon, that that you sort of evolve over time, that you learn from what you are doing, that you follow your own results and really look at, where am I going? And I really, the original concept of just moving as far as forward as possible with this two-phase surgery to now, looking at the soft tissues, and really what you're looking at are the soft tissues, is of course, an involvement of this thinking, and shows how great and wonderful you are in innovation in sleep surgery, and a fantastic surgeon, as I know as a colleague. So there are some questions, and I certainly also have a lot of questions. I want to drive some points home. Maybe if you don't mind, I would like to start with something. So, you said really what we are looking at are this, if I say in a nutshell, and correct me if I'm wrong, we're looking at how to change the soft tissues. It's not so much about the bone, forget about the cephalometrics. And we are looking at the symptoms. So, you know, you are a very experienced surgeon, but for the younger surgeons and for those of us who don't have this kind of experience, you know, how do you, how do you assess the soft tissues? You know, what does drug-induced, endoscopy play a role in that? I mean, you were talking about, you know, I look intraoperatively, I see the tissues are loose, right? So this whole complex, and, you know, I think we now see patients that are very symptomatic and they are operated on for their symptoms. But I think, you know, there needs to be also some kind of guardrails of how we make the decision for the indication between, you know, we are changing the soft tissue and, you know, we are treating the symptom. Can you sort of give us some guardrails for the younger of us and the less experienced of us on how your decision algorithm works?
Well, I'm gonna offend a lot of, probably majority of my otolaryngology colleagues. I don't do drug-induced sleep endoscopy, and I think that's one of the, for the lack of a classy term, one of the dumbest things I've ever heard. Okay, it's just, I'm just gonna take 30 seconds. One is artificial. Two, I'm sure many of us know people that snore when they sleep. If you stay up at night and listen to the way people, snoring is just a sound that generates from the airway. You listen to the sound that generates from the airway. It's different. Sometimes it's just heavy breathing. Sometimes it's collapsing. Sometimes it's regular snoring. There's so many different sounds, okay? But that's because the airway the airway is it's a musical instrument. It's a wind instrument. That's how you create different sound, right? And the airway contorts and in different stages of sleep. That's how you generate different snoring sounds or heavy breathing, whatever. During drug-induced sleep endoscopy, you're giving propofol or whatever short-acting it is, and you create a uniform sound, and you maintain that propofol infusion. So the snoring is uniform. What are we looking at? Or not we, what are you looking at? Okay, and it just, so when I look at an airway during surgery, I'm looking at, sometimes you just see that these tissues that you're managing, they're just really like dead piece of meat. There's no tone to it. Yeah, and like that, there's just no tone. And versus some people have, and now these people are paralyzed. It's the intrinsic property of the soft tissues. That's one thing. So everyone's different. So I try to do analytical stuff, but I couldn't. It's just an observational, observation. That's one. Second is that the soft tissues, as we get older, the soft tissues of the airway changes. It's damaged. It becomes a limp piece of meat. Okay, that's why the soft tissue response. That's why people when older patients don't do as well with MMA surgery. Although we manipulate the bone, the soft tissues are just, we lose the tonicity. And I call it, you age on the outside, you age on the inside. So,
yeah.
So really it's just try to pick at, you don't want to be aggressive, right? Because MMA is not a small operation. And I'm very conservative. So sleep studies. But patients are, and you have to make sure they have symptoms. Just because they have abnormal anatomy does not mean that they have sleep apnea, does not mean that they need MMA. And I'm trying to drive that because I see too many MMAs done, in my opinion, because people say, oh, I have a class 2 malocclusion. My orthodontist says, I'm going to have sleep apnea and I need MMA. That just doesn't sit well to me. I'm trying to be a doctor, not a technician. And that, to me, that's very different.
Yeah. Thank you so much, Casey. Zane, I think there are some questions in the chat, right?
Yeah, the first one's by if to raise a question in person by switching on the microphone or both microphone and video? Would you like that? Or should we?
Yeah, hi.
Hi.
Thank you so much for having me. And Dr. Casey, congratulations on such a wonderful presentation. After the presentation, we are all enlightened, much better surgeons than what we were at the beginning. Having said that, you actually answered my question. It was a little presumptuous. I had asked that in class 3 jaws or prognathic jaws, what is the role of maxillomandibular advancement? And,
Okay.
In a couple of cases, you did show, and how often do we see that?
You're gonna see that not too infrequently. Okay, like I said, I always ask about sleep symptoms. Doesn't matter whether they come in for whatever. Okay, so for sometimes the jaw is so huge, you're gonna have to set it back some. But I try to balance it by a fair amount of maxillary advancement. Now, the advantage is that even in class 3 patients, again, it becomes psychology. Class 3 patients always think that they have a huge jaw, a huge mandible. Okay.
Yes.
So when you do MMA, you have a lot of the movements, maxilla, the mandible set back a little bit. Their face is much more balanced, and they're happy. They're much happier. It's very easy to do to aesthetically improve a class 3 patient, but you just have to be careful. A lot of times, usually class 3 patients are not just projecting, but there's also long. So I do a lot of sort of a mandibular rotation to try to really limit a lot of sort of a posterior setback. I don't know, and
Okay.
yeah, go ahead.
Dr. Lee, there's another question which is attached to this. What would be the role of an orthodontist in your team when you are designing the procedure or planning? How much involvement of an orthodontist do you look at?
Now you're going to get me in trouble. Some orthodontists will tell me to do a plan or send a plan to me. I can honestly tell you that I don't follow the plan. Okay, because they're not in the surgery, and if something doesn't go right, I'm the one holding the bag, not the orthodontist. Okay, because I'm the one that's responsible. I definitely need help from the orthodontist in terms of some, position, the incisors and what have you. Number of Asian patients number of patients when they're already fairly protrusive, I tell them to do 4x extraction and retract the incisors when they're very proclined. To me, the whole thing about extraction causing sleep apnea and this out in the whatever universe is just, to me, it's bad. It's bad for all of us, and it's bad for the patient. I'm not saying that it aren't cases like that, but it's case by case, and so.
I'm so sorry.
Yeah.
Sorry about that.
So I think we should go on to the next question. Maybe,
question,
Zane.
yeah.
I think there's a question about that. It's sort of related, the counterclockwise rotation, right? So.
And there's one by to ask a question in person. No?
Yes, can you hear me?
Yes.
Hi.
Please go ahead.
Hi, thank you, Dr. Casey, for the lecture. Just wanted to know, do you encounter any relative or acroglossia? And do you feel the need, do you feel that there is a role of the tongue in obstructive tongue debulking procedures or any such thing?
Well, I think certainly in rare patients, macroglossia is a factor, especially in patients with Down syndrome. But you want to be very careful with tongue resection. Tongue resection for sleep apnea was done, especially with robotic, was done, probably 10 years ago. It's fairly morbid surgery. So a lot of patients, when I feel like their tongue is, for majority of patients, if not all patients, I always tell them to try CPAP first. And I like to manage patients with CPAP. And I use MMA when I feel like the indication's there, or the patients that are younger and what have you. So if the patient really has macroglossia, I will always go to positive ventilation with CPAP or BiPAP before I even consider any surgery. I'm very hesitant to consider any tongue-based reduction surgery.
Mhm. Yeah.
Right, right. Thank you.
Great. Our next question is by Dr.
Good evening, ma'am.
Hi there.
Good evening, sir. Thank you for the presentation. I wanted to ask that the counterclockwise rotation is a little unstable in itself. So after the surgery, is there any way to maintain that counterclockwise rotation? Because there are relapses have been seen that after the counterclockwise rotation, mild relapse will occur. So is there any way to prevent that relapse?
First, I disagree with counterclockwise rotation is unstable. It is unstable when there's a huge amount of rotation, where, when I do an advancement rotation, what have you, the position has to be passive, meaning that there's no soft tissue traction on the advanced skeleton. Okay. And I don't use HA. I only use autogenous bone that harvests from the bone marrow or whatever as grafting material at the posterior maxilla. And, my rotation is probably, the most is probably 8-9 degrees. I don't do a huge rotation because to me, that's just, I see people put HA blocks and all that stuff. That's when problem comes in. But, I do standard fixations, and I have not had problem with relapse with counterclockwise rotation. So,
Casey, I think I want to pick up one clue that you just said: fixation. Right? Sometimes we see people who use reconstruction plates and huge fixations with intermaxillary fixation with wires for 6 months, 6 weeks. And, there are still complications and non-unions and things like that. Can you sort of comment on what you use for fixation and why?
okay. So after this comment, I have to go see my patients.
Okay, so we have to close.
Okay, so at the end of the day, for stable, as you well know, Sabine, it's not just the fixation. It's how the operation was done. It's how you position the bone contact. It's how you advance it or you move the jaw so that there's no soft tissue traction on the maxilla that's going to put force on your fixation. So everything goes into it. It's not to, when you're doing the surgery, copious amount of irrigation so you're not burning the bone surface, so that where the bone is going to fuse at the osteotomy side. Everything goes into the stability of the operation. I hate heavy plates. Okay, I don't want heavy plates. I don't want big. I see huge reconstruction plates on thin females. Everything's going to show. I do regular, 1.5 or 1.7 maxillary plates, 4 plates. I'm not into all this, computer generated custom plates or what have you, because, it depends. And because in my hands, those plates have worked well for many years. For the mandible, I use positional screws, and I feel like, that the bone is lower on the thin side. I add a lateral plate that's 2 millimeters at the osteotomy side. That's what I do. If the bone is a little softer or thinner, I may keep them in IMF for a little longer in terms of week, maybe go to 2 weeks, and I may delay the soft food in terms of 4 weeks, 5 weeks, and that kind of stuff.
Yeah, thank you. I wanted to give you I'm completely on the same page with you. I wanted to give you the opportunity to drive that point home.
It's not just the plates, okay?
No, it's the bone needs
Entire
to be able to
surgery.
heal, right? It's the positioning, right? So, if we can, one more question. I don't know, Mac is raising his hand, and then we'll wrap up.
Okay.
And I just wanted to let you all know that we have a WhatsApp group. So if you want to join the WhatsApp group, we can continue the discussion. Yeah. So I don't know. Can you please introduce yourself? Who you are? You're raising your hand. Okay. It doesn't look like it, so my apologies. I know this was a fantastic talk. We, there's not enough time to take all the questions. Like I said, join our WhatsApp group, and then we can probably answer some more of these questions. I can relay them to Dr. Lee. And thank you, Casey, again for sharing your unbelievable experience, and Zain for joining me as a co-moderator from Jordan. And please stay tuned for the next events. And goodbye, everybody. And
Thank you for
good
having
day,
me.
good afternoon. And until we see you next time.
Thank you.
Bye-bye, everyone. Thank you, Casey.
Thank you.